Good morning. This morning we'd like to go ahead and talk about imaging for radiosurgery. And start out by saying if this was just going to be the talk about imaging, there would be two slides. It would be this is the CT protocol and this is the MR protocol, and that'd be about it. But in reality, this is an image-based procedure. And so when we do radiosurgery on Tuesdays, what you're really seeing is probably 25% of the effort that goes into radiosurgery. A vast majority of our efforts go in routinely in quality assurance, making sure all the reference systems work, etc. So what I'm going to do today is kind of talk through that process and explain a little bit what's happening. Okay. So they outline the objectives of stereotactic imaging, basic issues associated with medical imaging, how to do a contrast, spatial resolution, which is really key for what we do in image guidance, image resolution, acquisition time, which is always of concern, and then imaging modalities we have available to us, plain film, fluoroscopy, computed tomography, MRI, and then positron emission tomography, and a host of new ones that are coming online. So what's so critical about imaging? Radiosurgery is a treatment technique that fully relies on image guidance. There is no supplemental systems, and I'll explain what I mean by that in a moment. Often requires multiple imaging databases. Today, we're doing 5 radiosurgery cases, and 4 of them will have MR CT fusions, and the 5th one will have a CT angiography procedure. We're also doing a spinal radiosurgery that also had MR and CT fusions as well, and requires a reference system. And the reference system, as you most of the time refer to as a head ring, really has multiple functions throughout the procedure. Okay. The early radiosurgery techniques had to rely on plain film, and as such, we'll see had some issues associated with conformality and knowing exactly the shape of the target. They were rigid-based systems, and they did do the positioning well. Yesterday, Dr. Friedman talked about the early history of radiosurgery, and in the early history, we talked about Lexell, and this is the first picture of Lexell's first radiosurgical approach, which was his arc-centered frame system with a 250 kV X-ray tube mounted to it, and the X-ray tube would be pointed at the arc-centered target and then rotated around the patient, and as it rotated around, it always focused on the target. He then, as was discussed yesterday, went on to use particle beams and then eventually developed the gamma knife. This is another picture that was alluded to yesterday. This is Ray Gilberg, and you saw this picture yesterday. This is a patient that he treated in 1983. She gave me this picture about a month ago when we retreated her for her pituitary tumor. You can see the head ring that Gilberg used was a little different. The bars actually went into the face and not into the forehead. And while a lot of people complain about our head rings, she said they were much nicer than the one that they had used back in 1983. It's also been a long time. She probably just forgot. Okay, so the properties of the early reference systems were that there was a reference. It tied the patient rigidly to the reference, and then you got to put something onto the reference. In this case, it was an angiographic localizer, and most of you have not seen angiographic localizers. We stopped using those a while ago, and while they may come back, let's talk about that in a moment, we pretty much have given up plain film angiography. From that, we can get a stereotactic coordinate through some mathematics, and then come up with a trajectory, and then do the regular stereotactic procedure that you're all familiar with. Okay. When computed tomography came on the scene, things really started moving very quickly, and that's when the frames really got popular. And this is an early picture that was drawn actually here of one of the early systems, a BRW system, which was not an arc-centered system, but one of the early stereotactic systems that was used at the University of Florida. And the ability of CT scanning gave us the first true 3D databases. So we could actually, in the 3D database, okay. So radiosurgery is an external beam radiation technique, single fraction. And while some people do use multi-fraction techniques. We at the university here have only done single fraction radiosurgery. Stereotactic imaging, localization, virtual simulation, and non-coplanar beams. And these are all keys that will be discussed later on in the week. Okay. Now, when we talk about things being totally dependent upon imaging, these procedures are not. Okay. When you're actually using fiber optics to see where you are, you're not relying on your preoperative or intraoperative imaging. You're doing actual live visualization. This is a center picture of radiation oncology, where actually we'll be taking an image and then a second image, and by the overlay on the anatomy, you can see where you are, and you can do this in multiple planes. And this is a picture of a C12 screw being done on a live fluoro. And again, it's image monitored, but it's not an image-guided procedure. And so these are not examples of absolute trust in imaging. When you get to things like the Gamma knife and LINAC radiosurgery, then you calculate a target, and then you put the target at a point in space so that it is coincident with the actual radiation beams, and you have no other way of verifying that you're in the right spot. Then you're really relying on image guidance. Here's a picture of our some original drawings of our first machine, and what you can see with your mind's eye is the arcs going on the patient. You know your target inside the patient, and you have to not only be able to move the machine around the target, but you have to have a mechanism that allows the patient to move so that you can get non-coplanar beams applied to the patient. Okay. And in order to do this, this is what we spend a lot of our time on, making sure that everything from the localizers through all the targeting systems are aligned and actually do give you the same answer. And we can hold this tolerance within a few tenths of a millimeter. Okay. And when you think about radiosurgery, people always say, how accurate do you really need to be in radiosurgery? And the answer really is you need to be as accurate on every procedure as any procedure. So if you're going to do trigeminal neuralgia, you're going to do the 9,000 centigrade to the center of the trigeminal nerve, you better be accurate within a fraction of a millimeter. And once you do that, it kind of commits you to that type of accuracy throughout all of your procedures. We will routinely make adjustments when you watch us do treatment planning. We'll move things, a pixel on the screen with confidence that it truly is moving a pixel within the patient. Okay, so the objectives are deliver high quality, accurate treatment, non-coplanar beams, and we pretty much rely on the CT scan for our spatial resolution and our accuracy. We then rely on our MR sequences for and any other sequences for our contrast, tissue contrast resolution. And then by using image fusion, we combine these two and get the overall accuracy that we need for the system. Okay. When we look at things, people will ask often, how accurate do you need to be if you only have if your voxel size, and we'll talk about that in a moment, on the CT scan is a millimeter by millimeter by millimeter, why do you need to have sub-millimeter precision in the entire process? And the reason really is shown in this slide. It was something done by the American Association of Physicists in Medicine in the early days. They looked at all the errors you can have in imaging. And you take a look at the pixel sizes, you take a look at all the issues that you can have in the imaging chain, and it turns out that you're accurate to about a millimeter, maybe a little bit more, maybe 1.4 millimeters. And so this is this line drawn here. Then if you actually start to add uncertainty into your procedure, either non-rigidity in your reference system, inability for the radiation delivery machine to be on target, you start to actually add that in. And very, very quickly, after about a half a millimeter, that actually starts to dominate your overall inaccuracy. So if you want to know where you're placing a distribution relative to the patient's true anatomy, you need to really have your mechanical uncertainty ratcheted way down so that the imaging uncertainty is all that you have to deal with, and we can measure that, and we know what that is on a routine basis. Okay. So what makes this all possible? The head rings. And this is our set of head rings that we use at the University of Florida. You'll be seeing these tomorrow morning when we do the head ring Application lab. And the head ring essentially does two things. One is it holds the patient's head rigid for imaging and for treatment. And people always comment after you put the head ring on. It's interesting. I've done 3,000-4,000 of these, and probably half the patients comment, "Boy, this is really tight. I'm not moving, am I?" And that's the object of the entire exercise is to immobilize them relative to the reference. It doesn't really matter where they are in the reference. All that matters is that this reference, once attached and the procedure starts, stays rigid. And so while you'd like to get it nice and symmetric, you'd like to get the ring slanted along the AC/PC line, there are situations where that's not going to be possible. Patients have bone flaps. Patients have sloping foreheads. There are other things that we'll talk about in ring application, but what really matters is that things don't move. Okay. The ring itself is the one we use, which is based on the BRW system, has a coordinate system where the center of the ring laterally and anterior posterior is 0, 0, 0 in the middle, and the ring surface is at an axial coordinate of -80. So 0, 0, 0 in the BRW coordinate system tends to be in the middle of the patient's head. Right is positive, more superior is positive, more anterior is positive. It's a left-handed system. Okay. The pins and posts are all part of the system. The important thing about the pins and posts is that they stay rigid. And once you get that pressure on the patient and you get the head ring tightened down, they lock in place. And then you have to pay attention as to whether you're adding some sort of fiducial system like we did in CT or angiography, or whether you're actually mounting the ring. All those coordinate systems have to match. Okay? And again, tomorrow we'll talk about the ring process. But the important thing is that everything from here all the way through imaging, all the way through treatment is known, and all is relative to the ring reference. Okay, so let's talk about the actual imaging portions of it. Angiography is where we all started back in the 80s. We would use angiographic boxes. They had 4 fiducials in the front, 4 in the bottom. You'll see these projected on the angiogram when I show you in a moment. The mathematics for this was actually published by Bob Sidden. And so we get an AP and a lateral angio. And here's a picture of one of our first patients. And you can see the nidus of the AVM. And you can see the fiducial points. So based upon digitizing these fiducials and outlining the nidus, we can tell you where the center of this is and the center of this is, and it gives us the middle of the volume. Okay. Here's another view. And there's actually Dr. Friedman digitizing in those little spots. Okay. Now, why do we stop using angiography? Well, 2 reasons. One is we could, because we got a better database, which was CT scanning and MR scanning. The other one was that angiography does not give you the true shape of a lesion. And so if you look at these examples, these are just some easy ones to draw. You've got a nidus, and what you need to do in order to do a true 3-dimensional mapping is you need to be able to tell where this spot is in this image and this image. And because these objects are not regular, and it's very, very difficult to pick out the exact same spot for the entire surface of the nidus, all you could do is say, I know where the middle of it is here, and I know where the middle of it is here, and I can project back and I can find the middle of this, but I can't tell you where the surface is. Nor can I be sure exactly what the shape is, because on 2 projections, you can't do that. Now, it doesn't matter in a lot of the work we do in neurosurgery that you actually know the exact shape at any point in time, and knowing the point where you are is sufficient. But for doing conformal treatments, it really does matter that you can't tell that you don't have a bullet-shaped lesion, that you don't have actually a spherical or a rectangular lesion. The other thing that happens is that because you don't know the surface shape, when you project things down, you don't know if this ellipsoid or circle is being projected. They both project with the same diameters in these 45-degree views, and you can start making size errors as well. So there are a whole host of problems that angiography presents to you that that need to be rectified. Now, the real reason why we gave up angiography was that we started losing the ability to do film. And there was a period of time when you went down the angiography, you had this really interesting system. You'd have a film cassette underneath the patient and a film cassette lateral to the patient. And they would do a run. And when they did a run, you'd hear chakunk, 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 chakunk. And that was a film changer changing film after film after film. And you could get about 4 films a second through that system before the films would buckle and they wouldn't feed properly. But what happened then was that we started losing the ability to do film to image intensifiers. And image intensifiers did a lot for diagnostic radiology and for image guidance. One of the things they did not do was keep high spatial resolution. And so this is a picture of this grid using film, and this is a picture of this grid using an image intensifier. The image intensifiers had a very, very warped view of the world. And so you had 3 levels of distortion. You had bow distortion in 2 planes, plus you had fisheye distortion. So all of these made it relatively difficult to actually use it. Okay, so there's the grid, there's the undistorted, and there's the distorted. Okay. When CT angiography became possible, and even in the early days, it was a little more difficult. We had to wait for about the 3rd generation CT scanners to be able to do these scans fast enough. We were able to actually start to visualize the nidus and get a true 3-dimensional view of it. And this has really helped us in being able to plan conformally. And there's one of our, I think this is our 2nd patient that actually went through the scan. Okay. So what happens in a stereotactic CT scan is that we attach this ring. This has what we refer to as fiducial rods on it. There are 9. The tooling balls then lock into the ring, as we discussed earlier. Once they lock into the ring, we know the geometry of these bars relative to the patient, relative to the ring. And by localizing these bars, then we can process the image. And we know where every pixel, every voxel of that image is. And this is just kind of a picture of a map showing that we've actually kind of digitized this and calculated all of the coordinates relative to these rods. There are a couple of things you need to worry about when you image. One is the in-plane spatial resolution. Pretty much nowadays the scanners are set for a 512 by 512 imaging field. That wasn't always true in the old days, but nowadays it pretty much is 512 by 512. And if you have a 35 centimeter field of view, which is what you really need to scan the localizer, you wind up with an in-field pixel of about 0.67 by 0.67. So that's the in-field intra-slice resolution. And then the slice thickness goes in the other plane. And what we tend to do is take 1 millimeter slices, except when we do CTAs. When we do CTAs, we take 0.5 millimeter slices. And we do contiguous slices. So we take a slice, we move that slice thickness, we take another slice, so we have no gaps between the slices. So you have to worry about your in-plane and also your slice thickness, which gives you your outer plane resolution. Here's some examples of matrices. This is a 256 matrix. This is a 512 matrix. Same patient, same scan, same point in time, and you can tell this looks not as crisp as this. And there actually is something you've got to always be careful about when you're doing image guidance, which is the perception of a better image by having a thicker slice or less resolution. The image on the left appears to be a smoother, nicer image. It's less noisy, and that's because you have spatial averaging and things tend to look good. The same thing happens very often in CT and MR scanning when they do 3 or 4 millimeter slice thicknesses. The images look better because you have a better signal-to-noise ratio, but your spatial resolution is worse. So you've got to be careful about that. Okay. If we look at the intra-slice, or the thickness of the slices, and this diagram shows what happens if we go for a 1 millimeter slice transaxially and then reconstruct, go to a 3 millimeter slice transaxially and reconstruct, and a 5 millimeter slice transaxially and reconstruct. What happens is your spatial resolution in the Z plane gets worse and worse. So you need to be very careful about that when you're doing your slices. And our systems are set to catch this. If you give us 3 millimeter slices, you're going to get a phone call saying that we're not going to really accept the scan because we know we have some difficulties in processing. This is just a picture to help bring it home. Here's a skull with just some objects in it, just random objects. And here's a nice reconstruction of it with 1 by 1 millimeter scans, 512 matrix, 0.67 in plane, 1 millimeter out of plane resolution. And here's the reconstruction of it in the sagittal plane. You see the objects very, very nicely. And here it is with 5 millimeter resolution. If I showed you the actual slice itself, the slice itself, in plane slice, looks better. But when you actually try to reconstruct, you no longer know where things are. And so you've, again, got to be very careful about it. Again, just the two showing the difference between those two resolutions. Okay. The other thing that you have to be careful about is the scanner itself. We tend to spend a lot of time down in CT and MR with the patient scanning and making sure that we've got everything lined up properly. And what you assume is that the CT slices are going straight up and down, the patient is square to the scanner. And that's kind of a basic assumption, that the scanner has zero gantry tilt, that the patient is square to the scanner. In reality, though, when you actually go down there and you look, it's very, very difficult to get the patient truly square to the scanner. And there are two skews that you could have. One is shown here. The scanner is straight, but the patient pushes on the bracket. This didn't used to be a problem back in the 80s and 90s when CT tables were relatively rigid. CT tables nowadays are not. CT tables are made of carbon fiber. They're flimsy, they flex. They're made to be radiographically translucent. And so what happens is that the patients, when they try to get comfortable, press on it and they tilt it. And this is an exaggeration, but if you look at the processing, which you don't often see when we process these images in the background for you, we usually see a couple of degrees of tilt. And we need to be cognizant of that. We need to take that out of the imaging sequence. And this just shows you when we actually process the CT images, the screens that we look at look something like this. It gives us the axial coordinate. It gives us the diameter of the ring. And we know the diameter of the ring, and this is a check to make sure that the ring hasn't dropped, that it still has structural integrity. We look at the spin, how much is the patient rotated in the scan, and we look at the tilt. How much is he pushed in and out of the scan? We do that after we do it one other correction first. And that correction is a validation that the scanner itself is straight. If the scanner is straight and the patient's tilted, that's the example we just shown. The converse is that the patient is straight and the scanner is tilted. It's very difficult to tell which of these two you have on an individual slice. But if you have a series of slices, we can analyze a series of slices and we could actually tell whether the CT scanner is tilted or the patient's tilted. And we take out, because if we don't, this situation and this situation wind up in these two different imaging modality results. If the scanner is tilted, you get an incorrect warped image. And so the first thing we do when we process an image is we look at the image, we check to see, does the DICOM header on the image tell us that the scanner is straight? And then we do a calculation to say, is what the DICOM telling us true? And after it passes those two tests, we then go ahead and do the rest of the reconstruction. If it doesn't pass those tests, we have mathematical methods of actually fixing that. One of the ways we test this constantly is by having what we refer to in imaging as ground truth. And what we have here is a rigid phantom. It doesn't look like a ring, but it has all the features of a ring. It has places for those tooling balls to sit. It's got little mounts so that we can mount it into the stereotactic deliveries, into radiosurgery delivery systems. And we know exactly the BRW coordinate of each of these spheres. And we could take this and we could tilt it. And we can spin it, and we can tilt the gantry. We can do all of those tests I just talked about. And when we do all of those tests, and we do this very often, we go through and we take it and we square it up as best we can, and we look at the overall accuracy of all of those. These are the known coordinates. These are the calculated coordinates. These are the errors. And the overall vector errors turn out to be about the size of an in-plane pixel, which is about as good as you can do in imaging. And so we constantly are testing this with all of those errors I talked about to make sure that things are arced. Okay. We then take that system and we bring it to our delivery system and we lock it in, and we then actually treat that target and make sure that from the imaging all the way through we've checked the system from one end to the other. We do the same thing for your BRW biopsies. We have targets. We know what they are. We check the stereotactic localizers. We check the head rings that you use down in CT, and we also check the BRW stands that you use, the phantom bases in the OR. And those also go through a similar type of QA process routinely. There are other systems that we've developed over the years to actually allow us to put patients into position. Some of these are very similar to the ones we use in the OR. There are optical cameras similar to the systems we use in Stealth and Stryker in the OR now. It's testing that one. And these systems actually lock into the head ring just the way the localizers do. And it's just showing you locking the reference into the head ring. And then they go on the table, and then we can straighten up the patient and the table in the system. Okay. Prior to every treatment, just like in the OR, where you take out the stereotactic phantom base and you make sure everything is correct before you put that probe onto the patient, we have a similar process in radiosurgery where we actually take the phantom base, we dial in the actual coordinate of the patient, we take that coordinate system, put it actually onto the accelerator, and then from all different angles, we rotate the patient, we rotate the machine, and we shoot films, making sure that the target stays in the exact center of the radiation field, proving to us that from one end of the treatment to the other end of the treatment, everything is still rigid and correct. And we do this prior to every treatment. Today we have 5 radiosurgeries. We'll do this test 5 times. And then also, we have a list that we use that's going to run us through the procedure. We think those are 2 very critical things in our procedure. One is that we actually have a list, and all those of you who've read the checklist manifesto realize how important it is to have a procedure like that. When we actually went to the optical system, we did lose a certain amount of rigidity, and so the question becomes, you can put a bite plate on the patient. How do you know the bite plate goes back in the same position? When you put a head ring on the patient, the head ring stays there and doesn't move. The bite plate can move. And so how do you know the patient's putting the bite plate back properly? We developed a system of being able to test these bite plates. Here's the CT scan. We went through and just as we did with the ring systems, we put QA into the scanner link so that when we actually image these and we reconstruct this bar of where these balls are, that we actually can figure out the overall error of imaging, and that's part of the system. And then if the system actually moves, this is a patient that actually swallowed during the scan, we can also detect that the patient swallowed, and we can see that there's a misregistration error. And this is, as you think about it, this is something that's actually missing when we do stealth. And very often, when we do image guides in the OR, things tend to be off a little bit. And the reason why they're probably off is we don't have the ability to do all of these checks. We also have a secondary reference system, which is you're going to get down and you're going to use the operating microscope. The precision doesn't need to be quite as high as radiosurgery. But these type of errors, I think, do creep in on our day-to-day work, and I think we need to be cognizant that they could be there. To make sure that the bite plates do go back properly when we use this system, we attach a reference to the patient, and we have them put the bite plate in and out a number of times. And we've been able to prove over many, many clinical trials that our ability to actually localize something within a patient's head and with someone who has teeth is about the same as we can with a head ring. And if they're edentulous, we lose a little bit of precision, but not very much. Magnetic resonant imaging scanning. We've been relying on MRI for better part of 2 decades now to give us our contrast resolution. It didn't take very long for us to actually get both MRs and CTs and realize that the target that we were actually treating every day was the MR target, and that the CT target was a subset of the MR target. We didn't see as much. We didn't have as good a contrast resolution. We have gone to the extent that we actually do not give contrast to our tumor patients that we have MRs on any longer. We do the stereotactic imaging. We use that CT scan to actually relocalize and register the MR data set, but we actually don't give contrast anymore for our CT patients. So today, the only patient getting contrast is the one patient getting the CTA. In the image fusion, it's important to actually check very carefully that the fusion works. There are two things that can happen into an MR scan. One is that you will always have an MR scan that needs to be rigidly adjusted, meaning the MR scan itself has structural integrity, but the scan needs to be adjusted so that it lays over the CT scan. The other thing that can happen is that you can get susceptibility artifact in an MR scan. So it's important to look at the MR scan, look at the patient's internal anatomy, not just rely on their bony anatomy, not just rely on surface matching techniques. And we actually look at the sulci, we look at the ventricles, we look at the tentorium, we look at a lot of structures to make sure that we actually do have we look at the target areas. What you see on the left is a CT scan of an object, and on the right is an MR scan of the same object. And again, just like that tilted gantry scan, this is much more severe than you'll ever see. And if you actually do get a problem in an MR scan of this severity, you'll know it. The problem is, what you don't see are the 2 and 3% warps. And the 2 and 3% warps could lead you to 2 or 3 millimeter errors. And so having systems that actually don't give you the possibility of having these warped images by not introducing stereotactic rings into an MR scanner isn't a direction we decided to go in many years ago. The MR sequences that we use are relatively standard. We've tweaked them up over the years. There's a new MR scanner going in across the street now, and later on this week we will use our standard to go over there and scan and retweak these sequences. Unfortunately, I am the standard. So these are just some of the sequences that we've used over the years, and we use these for all different types of image guidance, not only radiosurgery in the day-to-day practice with the department. Again, here's a case of trigeminal neuralgia and some of the sequences we've used for that. And we actually can take multiple MR sequences, fuse them all to the same CT, and we can also use this technology to then fuse in time. So patients come back a year later, 2 years, 3 years later, and we can go back and refuse the technologies. Again, looking at the scans, and then being able to look at them in orthogonal planes, making sure that you actually do look at it very carefully and make sure it's correct. Sometimes this is one of the scans where we actually did have contrast in both MR and CT, and you can see that the CT scan contrast is not nearly as robust as we believe the better imaging MR scan presents to us. Okay. We've also used over the years 3D ultrasound, and this may actually have a resurgence in stereotactic body radiosurgery, especially for things like liver mets. This is just a picture of us back in 2001 doing a case where the lesion was too low for head ring location. And here's the MR scan, and here's the ultrasound localization of it, and the guidance system guiding the machine back to that position. So in summing all this up, the imaging has to provide a reliable frame of reference. The frame of reference has to be linked throughout the entire planning procedure and the entire treatment process. Multimodality imaging has to be accommodated. You have to be able to have the best imaging available to you that gives you the best contrast with the best spatial resolution to do these procedures. Every step of the procedure has to be part of a continuing quality assurance process. And a quality assurance process must be integral in every patient's imaging treatment process. So today, every patient will be part of this process. Everybody you see in the OR will be is part of this process when you do any stereotactic work. And again, what you see on a given day, tomorrow when you get ready to do DBS, today when we get ready to do radiosurgery, the few minutes of imaging, the few minutes of image processing is the tip of the iceberg. There is probably another if that's 20%, there's 4 times that amount of time being put into making sure all of these systems are lined up and accurate and stay that way. Things get bumped, things get broken. Our systems are designed so that if you actually drop a head ring and it is not correct anymore, if you drop a CT localizer and it gets misadjusted, they will fail our QA tests as we process these images. And that does happen. We'll get a phone call from Russ saying, you better come down here. We've got a drop localizer and we'll have to take the patient back. and rescan them. So all of these things are not just theoretical, physicists sitting down, smoking pipes and drinking whatever we drink, beer usually. But they really do have effect on the day-to-day imaging process. Thank you very much.